So welcome. Just a few housekeeping things before we move to our speaker for tonight. You guys should be doing your interviews this week if you haven't done them already. And just to make sure that you're on the right track, we will not have a class meeting next Monday night, but Wednesday, Thursday, Friday will be the presentations. So that will be our class meeting together. And then 2 weeks from tonight, we will have a class meeting, which will be our last meeting. So things happen quickly in the summer. So there's that. Let's see. I don't think there's anything. Make sure that I think pretty much everybody is signed up for a slot. You have to, I am changing it and I'm going to send out a notice about it. You will only have to view 5 presentations, not 6. So 5 in addition to your own. And you can show up, look at the sign up sheet where you signed in. You can see where other people have signed in, and you can just show up and be in the audience, and that would be great for your colleagues because they have somebody other than me to present to. If you do that and sign your name into the chat, that's all you have to do for each one. I will be recording all of them. If you can't watch all 5 in live, I will be posting the recordings on Canvas. You can go in, do a quick comment that shows me that you watched it, and then you'll get credit for it. So it's the easiest one is if you can just come and watch it live and sign in. But again, originally I said 6, but we do only have 10 groups. So if you watch 5 plus your own, that is the 6. So that's a little bit of a change, and I'll be sending that information out. But again, no class next Monday night. Our gathering for the week will be the presentations. So does anybody have any questions about that or any of the assignments coming up? There's a discussion board and a case studies worksheet that you'll be working on this week. But that's pretty straightforward. The more challenging one, discussion board post, I think, was the one that you guys did this past week. And I was really impressed with the quality of your responses. So great job. Okay, well, and like I said, I know that there's more people joining and there's more people that are going to be watching online after we record this, but I want to welcome our guest speaker for tonight. This is Jewel Ratcliff, LMSW, soon to be LCSW. She's finished her hours and passed her exam and done all of the other gyrations that they require, and so she's ready to go next month. She is a former hospice social worker. She currently is the director of social services at Regent Care Nursing Home in Kingwood, and also the chair of NASW Houston chapter. So she's here to talk to us about grief and the work that she does and has done with elders. So take it away.
Hi, everyone. As Ms. Beverly mentioned, I am Jewel, and I do currently hold the position of Director of Social Services at Regent Care in Kingwood. I did 2 years in hospice prior to that. And there's just a few things that I really think are important to mention about those positions. One of the main things I think that we don't think a lot about is anticipatory grief when it comes to maybe people that we're not related to. In the position that I hold now, these residents live in this facility, right? So both I have short-term and long-term residents in there, and there have been cases where short-term, meaning they came in for rehabilitation and they ended up quickly declining and getting on to hospice and passing. And so the grief that comes along with watching not just short-term but long-term residents that are living in my facility in their journey to decline and then moving on to passing is something that I did not expect. I have not had a significant amount of loss in my life. I've been very lucky. I have lost both of my grandmothers about 5 and 7 years ago. So it hasn't been very recent, and I haven't lost, many amount of people that I was close to. So I did not expect to have so much anticipatory grief and then grief itself when joining in these positions. I was taking care of my grandmother and doing CNA work in a memory care unit before I became a social worker. And that's kind of what led me into this path. And so even doing that work, right, there was some loss, but in this field, we build rapport with these residents and with the patients on hospice, right? We're one of the frontline contenders. They contact us usually with every single problem. In my LCSW supervision, Beverly has heard me say quite a bit that I often have many hats, not just the social worker hat. People come to me about everything because I'm the most accessible. And so the relationship that you build with these people are stronger than what, let's say, the nurse is building, right? They focus on medical care, whereas you're getting to know them as a person. So a lot of times there's a lot of fear and anxiety that come with, you notice a decline. Being in hospice for 2 years, I really picked up on the medical side of it and knowing what to look for when someone begins what we call transition. And so I can see it sometimes now, even before my nursing staff, when a resident is getting close. A lot of times you feel helpless because you know what's coming, and you're not sure how to really relay that in terms to family members. There's a lot of work that I have to do with the family, getting them prepared. So many people, even though they're in a nursing home, and you would think they've already lined up, their final arrangements. And that is, I'm going to say 80% of the time, not the case. And so you have to really have those difficult conversations. The other thing that really comes into play is you begin to question your own faith and spirituality. And it doesn't matter really your belief system as far as what you personally believe, but you begin to question it either way, right? Like these good people that are like the short term that are there, for rehabilitation, and all of a sudden they take a turn that you didn't expect. It really brings into questioning your own faith. And I wasn't expecting that at all. I'm not very religious. I am very spiritual, but I was not expecting for it to be so hard, I think, on that part of my life. The other thing that I think is very important to remember, and I know you hear it in every profession, is burnout. Compassion fatigue is something that it's unavoidable really in this field, especially in hospice. The physical aspects of being actually tired, changes in your sleep, the psychological from being, like, imagine your viewpoint right now on death, right? Very compassionate. You have empathy for people. A lot of times we get very desensitized to it because we're surrounded by it, right? And so we become a little cynical and humor and dark. I never thought I'd be a person that would make those kinds of jokes, but like the nursing staff does, and you get to be around them. It's almost like in first responders, they have to have a dark humor, right? Because they're exposed to so much tragedy. And so being in that field, a lot of times you get that numbness to death, and you lose interest. The the emotional aspects, right, of being angry or depressed, you begin to start dreading your work sometimes. I spent hours in my car when I worked in hospice driving from patient to patient. And that gave me a lot of time by myself, which also gave me a lot of time to think about each patient and what they were going through and family dynamics and how to help them, but also the dark side of it, right? Like, do they have their funeral home? Do they have their final wishes? You know, especially when you get families that are fighting over money, that is like one of the biggest things. And it is so hard to kind of stay in your lane, you know, and focus on providing care when that's what they're concerned about is, you know, who's getting what. The other thing is you get professional fatigue, right? Like there's reduced productivity, you have less joy in your job, you have less satisfaction. I spent 2 years in hospice and knew that that was enough. I couldn't go any further. I started bringing my work home, and you know, I distinctly remember this couple in hospice, and I just knew, like deep down, right, that would be my husband and I down the road. And so I came home and I just started getting on him about his health and his blood pressure and our final arrangements. And I'm like, listen, you know, we need to do our power of attorney stuff. And I just had a baby 9 months ago. So like in this process of hospice, I'm pregnant also doesn't help, by the way. But you know, he finally had to sit me down and was like, listen, stop bringing your work home. Like, you need a change of pace. So I ended up taking another job at 8 months pregnant, because I had to get out of it, which I'm not saying I don't love it. Don't get me wrong. I enjoyed that job. It takes a special kind of person, I think, to be with someone where they're at and meet them where they're at end of life. And it is very rewarding. And again, know your limits. Know when you've had enough, you'll know. And sometimes you need a change. And I think that's one of the best things about social work is you get the job opportunities are so diverse that you could change your entire setting. You know, I mean, I didn't take a very far jump, but you could if you wanted to. So,
So what were some of the things the rewarding things about the hospice job?
one of the most rewarding aspects is that you become a lifeline for this family. Yes, there's a nurse, right? And there's a CNA that comes in and provides care, but I apologize. I'm in the middle of something. Can you go find Randy?
Oh, where is he?
I don't know. Go find him. Thank you. I apologize. I also have teenagers. And there's actually a sign on the door that says treatment in progress because I did therapy and they just disregard it. Anyway, so you become a lifeline for this family and you get to see the changes, not just in the patient, but in the family as you're providing care and being there for them. One of the most rewarding families that I can think of is I got a call out at like 3 a.m. Because you're on call too. Most hospices do alternating rounds, but for a long time I was the only social worker, and so I was on call for months at a time. But I got a call out at 3 a.m. to just be with the family. They specifically asked for me to be there, not that they were in crisis, but that I had made such an impact that they wanted me to be there, you know, in that moment. And she thanked me, and she's actually a person, Beverly knows I don't have the best boundaries, that I still talk to, just because I made that connection with that family. You become a family member when you do it the correct way, right? That's the goal, is that you want them to welcome you in. You want them to feel very safe with you in order for them to be vulnerable. Because when you're losing a family member, or even when you're the patient and you're passing, it's a very vulnerable thing, right? And so our society tells us not to show weakness. And that is probably, you know, one of the weakest moments in life is that transitioning period. And so to be able to be there to provide support, you'll never know how much that means to someone. They can't express it. So I'll take a brief pause. Any questions so far? Okay.
If something to ask, you can put it in the chat too while she's talking. Address it then.
So there's some qualities that you really have to work on in order to work in this field. So the first one being your own self-awareness. I did not know that loss affects me very strongly because I have not had a lot of loss. However, losing patients at work and residents where I work now really do affect me strongly. So you need to have a good concept of what that looks like for you. I have had to excuse myself from a room because it just brings up a lot of emotion when a patient has passed. The other thing you need to be aware about is the way that you attach to people. It is hard not to get attached. And usually we're in this profession because we have, you know, a lot of empathy and we care so much about other people. And so that attachment that you build is very strong. I will not ever say don't get attached. Get attached, because it gives you a perspective of on treating someone, you know, in a way that other people just don't get. And so get attached, and then make sure you have the self-awareness of how this is going to affect you in the long run and what you need, which everything always loops back to self-care. I know y'all have heard that 1,000 times. When I was in school, I heard it in every single class from every single professor, but literally it really always loops back to that. So like, know what you're going to need. My favorite patient passed the day before I went on a cruise. And it was so hard. I went to her viewing and everything. That's the other thing, is a lot of times they ask you to come to those things. So I had only been to 2 funerals, other than 2 funerals in high school from some friends, but I have been to more now in that profession that I had in my whole life. And so I went to her viewing, and then the next day I shipped out on a cruise for vacation with my husband. And the first 2 days I slept through the cruise, really. Like, I just was so exhausted, and it had been so much because I had spent so much time you know, with that family and with that patient, that I didn't realize that it would take so much out of me physically, that the first couple of days I really did. I napped pretty much the whole day. Not that my husband minded, because he's been very used to, you know, me being in the field, but know how the effects of loss, you know, are going to affect you, which is something that you learn and it evolves. I do a lot better now than when I first started. I'll tell you that, but it's a growth experience. The other thing is working on your coping skills. When I was in hospice, you have interdisciplinary meetings once a week, and we would have a moment of silence and acknowledge the passing of a patient. And it's very validating. And it gives people the opportunity to say something nice, and, you know, you get a little more sense of closure, I think. In the field that I am in now, in my facility, I'm the only social worker. And so I work with nothing but, you know, business mindset people and nurses, and they don't have the same educational background that I have, and they don't have the same I guess level of empathy that I have. And so we don't have that. There is no acknowledgement sometimes, and I have to be the one that has to bring it to the table, because I need it. And I think that that's why it's important to advocate for what you need when it comes to coping. Not everyone is going to see it the same way, but I think just even that moment of silence, you'll find too, there's a lot of lack of time to grieve and process for them. like Beverly was mentioning, documentation is like the bane of our existence. And so even in those fields, hours of documentation, is something to be expected. And so everyone's kind of like, hurry up and get back to being at work, but take the time to process that, and also to acknowledge, the loss of someone. The other thing I think is really important is having resilient skills, being resilient, knowing how to self-regulate, being intentional with your time when you're not at work, having that self-validation, work-life balance. The job that I had in hospice is really hard to have work-life balance, because I even got a second cell phone because I thought I could leave my phone at home when I went and did things, and I couldn't do it because I have bad boundaries, and I acknowledge that. But it's an ever working progress, right? Like, I think it's something that we always work on. But I needed to know. I always needed to know, what was going on, and to be kind of up to date. Now, the job that I'm in, at the facility, they kind of mandate work-life balance. I'm not allowed to get calls when I'm on vacation. I have no access to my email or my system at home, period. They really encourage that balance, which I am grateful for, because I do have some bad boundaries with work-life balance. And like I had mentioned before, the self-care thing is something that it's another forever evolving and working on kind of situation. Even if you're great at it now, which if you are, I will take tips, because I'm still not. But it's forever a thing. How are suicidal ideations and suicide attempts dealt with, approached in hospice care? So we actually have had that situation in hospice. There's a term that you'll hear in hospice called snowing, which is where they over medicate someone to kind of with morphine to kind of speed up. Morphine has a tendency to shut down organ function over long-term use. And that's just coming from the education that I learned, right? Like, I'm not a nurse, but they requested their caregiver to administer the medication more than scheduled, because she was ready, and she had severe breast cancer. She was only in her late 40s, I think. And those are some of the hardest ones, is when it's someone young. So a lot of times we think about hospice and we think someone in geriatrics or an elderly person. But I mean, I had a lady that was my age, and that was hard. But anyway, back to suicide attempt with hospice. One of the things that you do in any profession that you are going to be in is safety planning, right? And crisis intervention. I didn't think I would need crisis intervention taking a job in hospice, and I really did, because there's a lot of times that you have to de-escalate. We had a lot of people that were considering suicide as a way out versus waiting. And they would call me in, and you have to have the skills to really try to talk someone off of a metaphorical ledge, and to, it's hard. It's hard. Even in the facility I'm in now, something that you might not know is that back in the day, there used to be asylums where people with mental illness went, right? Now, people with mental illness are either in jail or they're in skilled nursing facilities like where I live. So I have people with schizophrenia and cases of bipolar or disruptive mood disorder, and they're in there because they're incapable of taking care of themselves. And there have been multiple times where one becomes suicidal and they ask me to step in and de-escalate. And if you haven't taken a crisis intervention class, I encourage you taking one as a CEU, because the information is very beneficial. I took one in my bachelor's level, and then I did CEUs for it, and I still do CEUs for crisis intervention, because even if you don't think you're going to use it in a school setting or something, like they really come in handy. And encouraging someone to keep them going when they're at end of life is really banking that you have made that rapport. We don't really get the luxury of a second chance in hospice, right? That's not really something to look at. You need to start day one from the first meeting being a person that they can reach out to. And so building rapport and building that trust is like your saving grace. And a lot of times, I'll tell you, sometimes it's about having the family and training them to how to bring in like their past, because you haven't been there that long, right? So you don't know what their upbringing was, but having the family come in and provide that support during those moments, right? They start talking about the family reunion 10 years ago that, Bobby Joe got chased by a duck, and it changes the environment, right? And so you're going to rely heavily on the family when it comes to that kind of situation. And you're hoping that the family is in a good situation, because as I mentioned, there are a lot of times that they're in strife with one another at end of life. And so it's just a lot of moving parts and hoping for the best. In worst case scenario, we put the medication in a lockbox that only the caregiver had access to, so they could not administer too much medication to themselves. We've also done a placement into a facility when there was no caregiver, or the caregiver was not very trustworthy. And those are viable options, but not necessarily the ones you want to do as far as a placement for someone who may want to die in their home. Sometimes too, you'll find they don't want to die in their home. They'll ask for what's called respite. I don't know if that's something that y'all even talked about, but respite is where insurance will pay for them to go for 5 days to a facility to give caregivers a break. And there have been times where caregivers are trying to plan respite when a patient is transitioning because they don't want them to die in their own home. Right. And a lot of times you have to be honest with them if they're not in a position where they can be moved, right? And so we provide the support, and then often try to provide what's called continuous care, where there's someone at bedside 24/7 until the patient is they call it palliated, but really it means comfortable. Until the patient is comfortable, their anxiety is managed, their pain is managed, right? The family is managed. And so it's a lot of moving parts, and relying on what you've learned to connect with a variety of people. If you haven't taken cultural competency, also you might want to, because like that is critical. Something that I've learned in just last week, we had a family come in. The resident is from Pakistan, and they have specific faith belief system when it comes to death. And I had to write and make sure all of our nursing staff knows, exactly what the plan is when that patient passes. Because the family has to come in and provide certain kinds of care before the funeral home is even called. So it's important to know those kinds of things. or at least be willing to learn them in this field.
And Jewel, I think one of the most important things that hospice does in terms of suicide is that, you know, a lot of times patients is symptom management, because a lot of times patients want to die because the pain is so bad, or because something else, you know, there's a symptom that's out of control. And if we can get that under control, then they can have a better quality of life at the end of their life. So that is something that hospice provides, that, you know, works towards, you know, addressing someone who may want to die by suicide. But there's, you know, it's a tough thing, and we do a safety plan. We assess for it, right, at the beginning. Do you have these ideation, suicidal, homicidal ideation? Do you have a family history of it? But they're not always honest about that, or forthcoming. And so again, you get back to your rapport building and continuing to assess when you see changes. So making sure that, like you said, maybe drugs are in a lockbox, maybe firearms are taken off premises, or put in a you know, someplace else, or locked up. So there are lots of moving parts, as you said. So,
And you have to think to ask that question. Like the firearm question, I grew up in a household with firearms. Not everybody does. And so we had a patient that the spouse apparently had attempted that when he first found out he was sick. Had written a letter and everything. And so they had to have a family member take the firearms off site. Right? But to think about asking those questions, not everybody would. Or about like other old medications, right? Because when you're sick, you start getting a lot of pills. Then when you go on to hospice, the goal, right, is symptom management, but they usually diminish all the medications that you're taking that are like life prolonging, I should say, or like treatment oriented, and only leave comfort meds. And so, you know, asking either the patient or the spouse, are there a lot of medications here? Should we, you know, should we dispose of them or move them into another location to mitigate that risk of someone doing that? I think the assessment process is continuous, not only in hospice, but in our facility. So quarterly in a facility, you have to do a PHQ-9, a depression assessment, and it's documented. And then you do the referral process for psychiatric help if they need it. But it's more than just the process, right? Like I have a list of people that I visit weekly, that I make sure I stop in. And it's not because I'm providing something more than Deer Oaks is providing, right? I'm just someone that they see every single day, someone that they've trust, or someone that they've started building rapport with. And so I make it kind of my job to do a check-in weekly versus quarterly. So, you know, relying on your instincts of this person, I feel like needs more visits, even in hospice. This person, you know, is scheduled to see me once a month, but I think they would benefit from more. So, and you get to make that call, right? It's not, I never had my boss tell me, I think you should see them twice a week, right? It's usually you make that call. I think they need twice a week, right? And as they get closer, you know, maybe it is daily. There's also insurance at play, I'll tell you, and they'll say within the last 5 days of someone's life, you're supposed to visit every single day, and you don't always know, right? Sometimes you do, but it's a good thing to catch it and to make those visits to provide that care. But make sure you're being aware of the toll that it's taking on you to be for someone every single day. and still doing the rest of your job, right? Because it doesn't stop just because one patient is active. Let's see. I did want to mention too, about CEUs and stuff. One of the most helpful classes that I took, I don't know if you can see this. Let's see, is it gonna work? No, of course not, because I put a background on. But anyway, it's called the Grief Summit. If you're gonna do any profession, even if it's being a therapist, you know, the Grief Summit is a conference that really focuses on grief and bereavement and how to cope with it, but also how to help other people cope with it. And it was something that was crucial when I was in hospice, and I'm grateful that I took it even now. And it's usually in April, but consider taking it if you're in the profession of hospice or facility work. It's a really great conference. Any questions?
Yeah, the question was, what do you see are the needs of the dying person in terms of grief support, life review, all of that?
So sometimes it's being a person in the room for them to talk to. And just as you're going to question your faith and spirituality, they're going to, right? And it's really difficult sometimes, I think, to not let your belief system and be imposed on someone, right? I think a lot of religions are about, you know, missionary work, getting people to, you know, come into your belief system. And so finding the balance of being there and not offering your belief system or your opinions, but to be able to still be a support system, I think is difficult sometimes, depending on your religious background. Because I definitely was in the presence of people that don't have the same belief system as me. And I come from a point of student though, so like I really like to learn, but I think people that hold a strong belief system, a strong religious belief system, you might find it challenging. One of the things that the people that are close to death experience is the anxiety and the fear. Like Beverly mentioned, symptom management through medication is very important. And so being a team and recognizing when medication would be beneficial is something that you learn over time, right? I have no medical background, so it's not like I can make those calls from that perspective, but stating, you know, I was there for 3 hours and they were in a spiral of, you know, the fear and anxiety of getting close to death. Can we talk to a caregiver? Can we have a nurse come out and do an assessment and see where they're at? Having things in place medically is helpful, but also knowing what your skills are. Sometimes it's distraction, right? Sometimes it's talking about something else. If every person that comes to visit you wants to talk about why you're dying, maybe it's time to talk about something else, right? I mean, it doesn't always have to be about that care or about their diagnosis. And a lot of times, like I mentioned about being desensitized, people that work in these fields, people become their diagnosis, right? Like, oh yeah, that's the patient with breast cancer. No, that patient's name is Carly, right? Like treating them like a person versus treating them like their diagnosis is something that you'll really want to hold on to. I've had lots of conversations that had nothing to do with hospice care because they didn't want to talk about it. The nurse came in, was talking about, showing their decline on documentation. They've got rapid breathing occasionally. We had to bring in oxygen, things like that. And they're like, can we talk about the most recent UT football game? So meeting people where they're at, that is the biggest part. Wherever they are on their journey, if they just found out they're terminally ill and they're just now getting on to hospice, if they've been terminally ill for over 6 months and you're recertifying them for the next, it's meeting them where they at on their journey.
And sometimes they just want to talk about their life, or
Yep.
Yeah.
Their accomplishments. I once had a patient in hospice that was a writer that traveled the world with his wife. And his memory was going, and he just wanted to talk about the same place that him and his wife went. And I heard that story no less than 50 times. But each time I acted like it was the first time he told me, because that was his biggest memory. And sometimes that's what it is just hearing them out. See, have you worked with children in hospice? What is the most challenging? So my company did not have children in hospice while I worked there. I think in the profession that does happen, and that it would be very hard for me because I do have kids. I don't know how I would handle it, but I did work with women who had children that were passing. And that was significantly hard because you're preparing their children for the loss of their mother. And again, I would bring it home, and it really puts things into perspective, especially the young mom that I had that had a 5-year-old, and the dad wasn't in the picture. The grandparents were the ones that were going to be taking over care, and they had their own health concerns. So the most challenging part when children are involved, I think, if they're on hospice or they weren't on hospice, I think the most challenging part is putting everything in place to support every scenario, because it's impossible. It is impossible. You can't factor in everything, but you can do the best that you can. And so one of the things that I also did, I was bereavement coordinator, which means I also followed the family for a year after the passing. I think was very lucky for me to have both roles, although it was exhausting to carry both roles. But I got to follow the family, and I made, I guess I would call them therapy visits to the kids afterward, and to check in with them and see how they're doing, and recommended, like for the family to tell the school. They may see a fluctuation in their grades, right? They may see a change in their behavior. They just lost their parent, and working collaborative with the school and with the family to kind of put things in place. Maybe they need the 504 program temporarily, while they're coping with the loss of their parent, or making recommendations and referrals for a psychotherapist outside of school, right? I think they would benefit from seeing a counselor outside of school. And sometimes it's setting the whole thing up, like their insurance, finding a provider in their insurance, right? Because they just lost someone. They don't have the spoons to do all of the things that are needed. And so you just fill in where you can, right? Like I brought a meal over to a spouse, like for his family when he lost his wife. And it wasn't because I felt like I needed to go above and beyond. I felt like that's a basic thing that anyone could do, and they didn't have a strong support system, right? And he's having to learn how to cook because he never cooked, right? And so I just took a meal over there, and it was, this grand gesture for him. And for me, it was, I made extra. I fed my family and I fed his family because I have a big family. But you fill in, it's about filling in where you can and meeting people where they are. And I think that goes in any profession. But I don't think I could have done children. I think it would have been significantly hard for me.
Hospices in the Houston area, or I think anywhere that treat children as patients. And one of the reasons, unfortunately, is that there's not insurance there for it. There's not a good payer source, and it's much more labor intensive than it is to care for an adult. There's a lot more involved just in providing support, as you might expect, to the family, and more medically usually going on. They're usually a lot more aggressive. They maybe aren't stopping chemo right away when they have when there's children involved, some other things, but so financially it's hard for some hospices to even offer that, and mostly it's the nonprofit hospices that offer those services. But yeah, so that's kind of a macro social justice issue right there.
Speaking of that, I think the most challenging case that I had was a family that lived in Fifth Ward, whose door had been kicked in multiple times, and they were a Hurricane Harvey survivor, and so their house was falling apart, and their front door was rotted on the bottom. And I was just trying so hard to get, FEMA or Habitat for Humanity, someone to come and help this family. And I couldn't get them fast enough. And the hardest thing is knowing that you go home to your house and you're safe and secure, and that there is a family with a family member on hospice, and people have kicked in their door and taken their medication. So, and there was nothing my boss told me there was nothing that I could do if I couldn't get resources. So what I did, just in case you're curious, was I got someone on the Nextdoor app, a neighbor, to buy a door from Lowe's, and then I had a volunteer, my husband, put it in. Because I could not sleep knowing that they were not safe, right? Like in hospice, you think you're providing care to a patient, because they're at end of life. But when you think of Maslow's hierarchy of needs, my goal was to get them safe first and foremost. We can work on the other stuff later, but safety was first. Eventually, we got them moved into another home, which I was very grateful for before they came off of services. But I definitely had my husband put in a door. And if you don't know someone, or you don't have a husband that's like, sure, babe, whatever you need, the Nextdoor app, I utilize that more times than not, for donation stuff, because insurance doesn't cover everything. I still use them now. Like when I discharge a patient home, insurance doesn't want to pay for a shower chair. Insurance doesn't want to pay for their bedside commode. So I work with Kingwood Kindness of Kingwood, forget what their name is, and like other organizations that are local over here to donate medical equipment when I can't get insurance to pay for it, because insurance is the devil in my opinion. It never wants to pay for what they need, right? And sometimes they'll discharge someone before you think they're ready. And there is grief involved with that, just because they need more time.
You're talking about the nursing home discharge.
At the nursing home. Yeah. I've had to send a patient home with a family member who could not lift them, and they could not walk yet. But insurance said that this was their new baseline and they would benefit from home health. So I called in the best home health and I got all the equipment that I could. And I also took meals to them because I I just felt like they needed help. It's a hard job. I think they both have difficult tasks. However, they're both very rewarding. I would do it again. I would. I would do hospice again. Now that I've gotten out of it for a year, like I would say I would do it again. Any other questions?
I have a statement, and it's kind of off topic. I've been I don't have I have a master's in public administration. I don't have a social work background like a lot of you guys have. But I stumbled upon social services about almost 2 years ago, and I work for an amazing agency here in Fort Worth. And since being here, how can I say this nicely? A lot of social workers are not empathetic. I think that they've become desensitized, and that affects morale like big time. So hearing you say these things, I'm like, oh, there's still some that's in here. There's still a few empaths like me going above and beyond, because I think we have to have boundaries with that. But then it's also like, why are you here if you're not going to be, one of those people who are going on an app and having volunteers, assist people who really need help. So good for you.
I'll tell you, be the light. I've worked with other social workers and I have an intern. This is a perfect example. I have an intern. She's in her bachelor's at Prairie View A&M. She was so gun-ho for change when she started with me in my facility. And now she's like, I'm just going to do my part, and I'm going to get my hours, because she sees how difficult it is to change the minds of people that don't have social worker background, or they've lost their touch with empathy. And I tell people, be the light, just keep going. If I can convince her that it will happen one day, it's a forever going battle, but it will happen one day. Don't give up on it, right? So when you take a job with other social workers, especially someone that's been in the field 25 years, you will see burnout like you have never seen it. Be their light. Show them what it's like to be what people call a baby social worker, but where you're still passionate and driven. I started in social work in 2016, and I think that the thing that gets me is that when I see people that have lost touch with empathy, I'm like, no, if I can do it, I'm going to do it. Like, create the change you want to see. So don't give up on them, that be their light, that beacon of hope. Because if they see it in you, they'll be like, man, I remember when I was like that. What happened? And then they do that internal analyzing of, yeah, I think I need to get back to that and how to do that. Right. And a big part of that is the self-care, because I've been burnt out.
Absolutely. Self-care is not just a nice thing that you do for yourself and you get a massage every once in a while on your birthday. It's like brushing your teeth. You've got to do it. You've got to do it to be healthy and functional, and you deserve it. You're a human being in this world, and just like your clients deserve care, you deserve it too. And so it's not just take care of yourself so that you can take care of other people. That's a nice thing, but it's at the base of it is you deserve to care for yourself as well. You're a person of value. So Well, you want to talk to us a little bit about NASW?
Yes. So as Beverly mentioned in the beginning, I am the new Houston branch chair for NASW, the National Association of Social Workers. It is a good opportunity for students. I actually joined and when I first started my bachelor's because I was like, there's an organization where I can network with a bunch of social workers and like have the information on standby, like when you need something, right? Resources, when you need resources, this is good beneficial, but the connection with other people. And so I encourage you to check it out. If you have any questions, please, I'll give you my information. The conference is coming up. If you look at the prices, you're going to tell me I'm not paying that. But the good news is, as a student, you don't have to, and you can volunteer, which is something that I did. And I strongly encourage because you get to see the behind the scenes of the conference, but you get to network with some of the bigwigs that are presenting. And so it's a great opportunity to learn, to network, and to make connections that are something you're going to utilize your whole profession. When I volunteered and I was in the same room as, her name is Josephine Titsworth, and she is an amazing presenter, and I met her as a student and I am still connected to her now. And we have done some work together with LGBT rights, but it is an amazing place to have connections that you can utilize down the road. So I encourage you to check out the conference. Oh, I'm so glad you remember. So, and there's a bunch of chapters, even if you're not local. I'm over the Houston branch. If you're in a different area and you're not sure who your branch is, let me know. And Houston is very vast. So like, you might be in my area, even if you don't consider yourself Houston. But it's a great opportunity. We have meetings via Zoom on the second Wednesday of the month, just to check in and hear upcoming things. And the NASW does a lot of advocacy at the macro level, and they keep you up to date with what's happening in the legislature. But they also have CEU events and things like that. And usually if you're a member, you get it out of discounted price because CEUs is something you're going to have to get once you have a license anyway. So I strongly encourage it. And there are other, I always tell people, there are other social work organizations, you know, check them all out. But the NASW is the one that I chose and that I've really appreciated working with. So.
Any more questions? I don't see anything in the chat or comments. Well, I appreciate you all coming out, and Jewel, thank you so much for sharing so honestly and candidly, and also giving us a whole wide view of what it's like to be in the field. And we're going to be learning more this week about end of life care and hospice care, and this week and next week. So this was a great introduction to all of that. So thank you so much.
No problem.
And good luck as you embark on your LCSW starting next month. Congrats.
Yes. I am so excited about that. I am going to put my information in the chat just in case anybody has any other questions. If you need anything, we're in this journey together, right? And we're a team, even if we don't work in the same place, even if we don't work in the same field, right? It's about teamwork because it takes a community to make change. So I'm also ahead of some Facebook groups, social workers in Houston, stuff like that. So just let me know if there's anything I can do or if you need anything.
I have another question. Well, yeah, this is an actual question. Tell us about this exam, because I'm a part of a few Facebook groups too. And at first I was confident. I thought, I'll go in and ace this thing. And after joining those groups, I'm like, your 8th time, your 7th time. How do I prepare for this? And so I've done all the things in preparation. Like I have all these different books and I'm a part of all these different groups and stuff now. But what did you do to prepare for the licensing exam?
So
Yeah.
I'd be happy. Go ahead, Beverly.
The LMSW exam you're talking about?
Yeah. Mm-hmm.
So I will be happy to share, if you email me, I will be happy to share my study guides because that is exactly that's what I do. I create study guides because the information overload that happens when you start to prepare for an exam is insane. Also, the people that are on their 8th time, a lot of times have had a huge gap from their education to when they're taking their exam. So I took my exam right after I graduated, and the test really follows a lot of what you learn. And so when you're fresh out, I think is the best time to take it because that information is fresh in your mind. Also, I will say limit the amount of things you're studying. I know we want to absorb all the information that we can, but try to stick to like one direct thing. The other thing that I did was I did a lot of practice tests.
Yeah.
Because I wanted to see where I'm at. When I paid the ASWB for a practice exam and I passed it, I was like, I got this. Like, because they're very similar, right? And so the other thing is if you have test anxiety, learn how to mitigate that before you do. So I'm lucky. I don't have test anxiety. I do have study anxiety, which is why I created study guides because I was studying 100 million things. And I too am in all of those groups, and I was in all of those groups for the LCSW too. And I regretted that decision because there are people on their 8th and 10th time. And I just was like, oh my gosh, like, how am I gonna pass if they can't pass? Right. But it's different for every person. They get different exams. Also, there's a lot of things in progress now to try to make the exam more passable. Something else the NASW is working towards. So the test that you're going to take is different than the one that I took, but I strongly encourage like practice tests, practice questions on, is it like Quest or something? It starts with a Q. I'm trying to remember what it is, but
Did you use the AFGAR book? That's what everyone.
I did
Okay.
for both tests.
Okay.
I did. And I passed them both on the first try.
Wow.
So
And there's
Dawn Apgar does a very good job.
Pocket Prep is the one, I don't know that I know there's others, but Pocket Prep has a lot of, it's all questions. Yeah.
Yep.
Yeah.
And if you do the paid one, I think there's 1,100 questions on the paid one. And so you literally go through all the questions, like all the possibilities that could appear on the exam. You go through that. So you get a 6-month subscription for like $100 or something like that. I think it's worth it.
And they're very similar. So I had the last edition of the Dawn Apgar book for my LCSW, and I went ahead and bought the newest one, and they were pretty much the same. I did it anyway, but they were pretty much the same. There was a little difference in the questions because the way they write the questions had changed since the last one had been published, but it really, she does a really good job of explaining everything. So that's a good resource to use. But if anybody wants the study material, send me an email. Just remind me, like, hey, you said that you had study material for the LMSW. I'll shoot it over to you.
And if they're taking it 7 or 8 times, that is test anxiety. Yeah.
Or there's something specific that they're not grasping, like a certain section. Like in my LCSW, I had a hard time with diagnosing, like remembering the criteria for each one. And I'm a person that's like not really for standardized testing in general because we all learn differently, but also I have access to my DSM and everything in the real world. I'm not going to be trying to remember it. I'm going to look it up and make sure that I'm correct. Right. So, but yeah.
Also,
it's not as bad.
I feel like a lot of those people who aren't passing multiple times, they're not utilizing all of their resources, because that's one thing I noticed, like, oh, I didn't want to buy the book, it was too expensive, or I didn't want to take that study, class, it was too expensive. So it's like you kind of got to do what you got to do.
Yeah, U of H does a licensing prep course, and I took it, and I'm glad that I did. And at the conference, they usually offer one too, and I did it for the BSW level. I never got my LBSW because I just jumped into the LMSW, but I took the course for licensing prep at the LBSW level at the conference. So, yeah. And if you volunteer, you get access to those classes that you're not helping in. So, and it's a way lower, I think it's like 40 or 60, whereas I just paid 310. So, but it covers a lot. It does.
21 CEUs.
Mm-hmm. Yep. Everything you need in one place. And they have an exhibitor hall that I love. And there's always people with cardigans and sweaters, because everyone knows social workers wear sweaters, right? So like, I love the vendor hall. I'm a shopper.
I wanted to come. I actually reached out to someone months ago about it, but my agency is also giving a conference that weekend. I mean that week, same dates.
Mm-hmm.
So I couldn't make it, but maybe next year.
Yeah, we're supposed to be camping that weekend. So that Saturday, I'm going to leave from the conference to go camp.
That'd be fun.
Mm-hmm. The Houston conference is the October 12th through the 14th. And it's in Galveston.
Actually, Texas, right? The whole state.
Mm-hmm. It's a state conference. So there's people from all over Texas coming down.
And you will be having a call, a Zoom call.
Mm-hmm. On the second Wednesday of every month. Let me see. The next one is August 9th. Let me see if I can. Feel free to email me about that if you'd like the invitation for it too. So you can come and check it out and meet a few people.
And there's and if you're in the Houston area, there's an NASW Houston Facebook page, right? That has a lot of that information.
National just made us change it.
Oh.
So there is a page.
Mhm.
There's no longer a group, but I'm still over the group. It's just got a different name now. But yes, there is a Houston page where we post CEUs and upcoming events and things like that. So, and I know Fort Worth has one too.
Yeah, I'll be shooting you an email.
I am happy to be a resource. I think that's one of the most beneficial things is once you get your license is reaching down and pulling people up to where you're at, right? Elevate. That was last year's or the year before's theme for NASW was elevating. And so I really try to do that.
Anyone else before we close for the evening? Again, thank you, Jewel, for spending this time with us tonight. Really, really appreciate it. And thanks everybody for coming out or for watching later on Canvas. And if you're watching on Canvas and you want the contact information for Jewel, just let me know and I'll provide that. Okay, well, have a great evening, everyone. And yes, thank you so much. And reach out to me, guys, if you need anything for your projects or for anything having to do with the course. And we will see you soon. Take care.
Thank you, everyone.
Good night.